Welcome to the Introduction to Implementation Science in Global Health. This talk intends to provide a definition on implementation science, and at least how we are looking at the field of implementation science in global health here at the University of Washington. In the field of implementation science, we're concerned with closing the no-do gap, which is a term coined by the World Health Organization to refer to the gap between what we know works largely from efficacy trials and their implementation at scale to lead to population-level health improvements. Clearly, there's been a large amount of investment and production of advancements in medical science over the past 2 decades, and we have seen this gap grow while the implementation and scale-up of evidence-based interventions continues to lag behind. Consider that currently there are an estimated over 10 million annual deaths from disease that have proven low-cost prevention or treatment strategies like tuberculosis-related mortality, HIV-related mortality, preventable child mortality, and maternal mortality. And if you look at the pie chart in the figure in this slide, you can see estimates from a demographic health and surveillance system from the Rufiji district in Tanzania, where they collect ongoing data on mortality and demographics and cause of mortality. And it's estimated that 85% of the disease burden in the district in Tanzania could be prevented by available cost-effective interventions that just aren't being applied systematically or at scale. As we pick apart the no-do gap in more detail, we can look at delivery systems and their role in taking interventions with a proven evidence base and implementing and scaling them up. And we can see from the table here in slide 3 that coverage of basic services through the primary healthcare framework does lag behind in low-income countries compared to the rest of the world. Things like antenatal care coverage, births by skilled health personnel, measles vaccination, although oddly in the case of antiretroviral medicines for patients with advanced HIV infection, the coverage rates are higher in low-income countries compared to the rest of the world, which provides some insights into the role of delivery systems and the role of financing in closing the no-do gap. And you can see in the second table below data from our U.S. healthcare system, which demonstrate to me that finances are not the only determinant of implementation and scale-up of evidence-based intervention, but something else is going on. If you look at these data, they come from our Medicare system. And for those who do not know the Medicare system of the United States, it is essentially a universal insurance coverage system primarily for older Americans, those over 65 years of age. And looking at some basic quality indicators that are highly protocolized or that are covered by health insurance and are supposed to be administered routinely to patients who have entered into the care system, you see that we fall quite short of our aspirations or our goal. Consider that beta blockers are only administered to 69% of patients who are admitted into hospital with signs of a myocardial infarction within 24 hours of admittance. Or antibiotics, in the case of antibiotics, for those who are admitted to hospital, they're only initiated within 8 hours amongst 87% of patients. And for preventive services like mammograms and routine lipid panels, we can see that we're falling even shorter than other protocolized interventions, even though these are paid for through a universal coverage scheme. I'd like to look at the example of Mozambique and the rollout of antiretroviral therapy in Mozambique, where a survey was carried out amongst 32 health facilities with comprehensive HIV care and a nearly equal number of patients who were on antiretroviral therapy, as well as those who had not yet initiated antiretroviral therapy, where patient charts were pulled to look at the implementation of evidence-based interventions that are part of the Ministry of Health essential package for HIV care and treatment. And you see similar patterns as in the U.S., where evidence of a CD4 test in the patient files in the 6 months prior to the study was only found in less than 66% of patients, and only 79% of patients who were eligible for initiating antiretroviral therapy had evidence of initiating antiretroviral therapy. And we fell much shorter in terms of cotrimoxazole prophylaxis as well as tuberculosis screening. Now again, this could be a question of resources. I think something else is going on. What you can see here is further details of the 32 health facilities that were included in this study looking at evidence of tuberculosis screening in patient files. And you can see two different populations here. In the red bars are those patients who are on antiretroviral therapy, and in the blue bars, those who had not yet initiated antiretroviral therapy. And what you see here is typical for a lot of health services research, where you see a tremendous heterogeneity of implementation measures across the different facilities. And some could be related to hospital size, but when you look at the size of hospitals, for example, Xai Xai Provincial Hospital has very high coverage rates or evidence of tuberculosis screening amongst HIV-infected individuals who enroll in care. But a similar sized hospital like Chimoio Provincial Hospital falls short, much shorter than Xai Xai Provincial Hospital, which raises question about, well, why is there such heterogeneity here? In the field of implementation science, we're trying to address these systematic questions that can try and raise all the boats to improve performance so that there's more homogeneity of performance and higher successful implementation of evidence-based interventions in addressing those bottlenecks, which may be very specific to specific contexts. But it's not necessarily just a resource question. And as Don Berwick from the Institute for Healthcare Improvement has said, every process is perfectly designed to give you exactly the outcome that you get. Or to say it another way, there's something that we can do to improve the systems to work better, to get better outcomes. Part of the no-do gap is the implementation bottleneck. And what you see here is a picture from central Mozambique of a rural hospital. And in this particular photo, it is a well-child care service. And this is a type of environment where basic services are implemented. Vaccines, primary healthcare services, maternal and child health care services, pharmacy or drug therapy services, and in the case of this rural hospital, basic surgery. So this is where the rubber hits the road in terms of the implementation of evidence-based intervention. Over the past 20 years, we have seen an explosion of resources for development assistance for health. This slide here from the Institute for Health Metrics and Evaluation shows increases over the past 20 plus years of resources for development assistance for health. And what's striking is that there was a doubling of resources from 1990 from $5 billion to $10 billion per year for development assistance for health. And from 2000 until 2010, there was a further tripling of resources from $10 billion to $30 billion for development assistance for health. And what this investment has given us is a great opportunity in terms of new tools to put into our toolkit to prevent and treat some of the major drivers of global morbidity and mortality. Things like the microbicides for HIV prevention, pre-exposure prophylaxis, option DB+ for prevention of mother-child transmission, other HIV preventive tools and strategies, new malaria tuberculosis drugs and diagnostics, new combination therapies, new vaccines, and drugs for neglected diseases. However, it is the same implementation system that will be charged with delivering and scaling up these new tools that we have in our toolbox, which further underscores the importance of understanding and dealing with the implementation bottleneck. Often when we talk about the translation of efficacious interventions into population-level health outcomes, we refer to them as steps of translation or the translational highway, where we have discovery, development, delivery, and improved health outcomes. You can see for the different steps that we ask different questions. At the discovery stage, the first steps of translation, we're really asking questions around what is the pathophysiology, taking information from the laboratory and developing candidate therapeutics, candidate diagnostics, or candidate preventive technologies. At the stage of development, or the second step of translation, the questions we're trying to answer are related to the diagnosis and appropriate intervention. So we're developing candidates into models that can be tested in the human population to define or identify the efficacy of these interventions. And the fourth step of translation, improved health outcomes, the types of questions we're answering are, does the intervention and delivery model work? Are we having the intended effect on population-level health outcomes? But the step of delivery, or that third step of translation, really trying to figure out how do we best deliver the intervention to those who need it? How do we understand and improve delivery systems to bridge that gap between development and leading to population-level health outcomes? And I've identified the box of delivery as a black box, or as some have called it, a black hole. It's a black box of delivery because health systems or delivery systems are very complex. We often don't know what are the drivers of effective delivery systems. The pathway towards improvement is not always very clear. But it's also a black hole because resources for health systems are seemingly endless, and that we can put a lot of resources into improving health systems or delivery systems, and we're not exactly sure how to maximize those resources. But clearly, answering the questions about how do we best deliver interventions to those who need it, how to make delivery systems more effective, is essential in closing the no-do gap in global health. What you can see here in this graphic from Proctor and colleagues in 2008 is your classic logic model, where typically we focus on, do intervention strategies, the usual, lead to client outcome improvements in client satisfaction, improved functioning, or improved symptomatology. While implementation science has typically focused on the inner workings of implementation strategies, implementation outcomes, and service outcomes. Or as we look at different ways of implementing evidence-based interventions, different organizational level interventions, different interventions targeting groups or improved supervision, do those sorts of interventions lead to improved implementation of evidence-based interventions, improved feasibility, improved adoption, acceptability, sustainability, and does that lead to more effective and efficient services? But in my view of implementation science, the core of implementation research is much broader, encompassing not only the inner workings from does implementation lead to a more effective service, but also getting more upstream to focus on evidence-based practices and also looking at client outcomes. So when I view implementation science and the core of implementation research, for me it is much broader and encompasses the intervention strategies, those evidence-based practices, as well as implementation outcomes to service outcomes and ultimately client and population level health outcomes. Because ultimately that is what we care most about. Our evidence-based interventions and our implementation strategies leading to population-level health improvements. Bringing us to the formal definition of implementation science that we'll be using throughout this course, which is a systematic scientific approach to ask and answer questions about how to get what works to people who need it with greater speed, fidelity, efficiency, quality, and relevant coverage. Now, there's a lot in this definition, so I'm going to go through the different elements. One is that we see this as a systematic scientific approach. We are bringing together multidisciplinary methods into a framework that we will apply systematically to close the no-do gap. And it is scientific in that we are asking and answering questions. We are putting forward hypotheses and trying to answer those hypotheses. We're focused on getting what works to people who need it. Now, from what works, I'm referring to interventions that have a strong evidence base. Interventions that have gone through a phase 3 clinical trial or an efficacy trial, or through observational data, we have a strong, robust set of information to underscore the evidence behind our interventions. And we're focusing on getting it to people who need it with greater speed, fidelity, efficiency, quality, and relevant coverage. So greater speed, focusing on closing the no-do gap faster. Currently, it's estimated that it takes 17 years on average to go from the development of intervention to its implementation at scale, and that simply is not fast enough. To do it with greater fidelity. Fidelity refers to the core components of an intervention that need to be present for that intervention to have maximal impact. Taking into consideration that interventions will adapt for different settings, fidelity refers to those core components that must remain for maximal impact. Efficiency, because we are dealing with limited resources. Quality speaks for itself. And relevant coverage. Relevant coverage refers to the fact that it may only be specific individuals or specific population groups, subpopulations, who we are targeting with interventions. So we want to maximize coverage, but it may only be relevant to specific subpopulations. I mentioned implementation science is a systematic and scientific approach. We are borrowing from a number of different disciplines. And throughout this course, you'll be hearing methodologic lectures from a variety of disciplines, and what we're focusing on is how can you apply these methods to better understand and improve delivery systems as that critical link between the efficacy and impact at a population level, as that critical link for closing the no-do gap. So we'll go through surveillance and data systems, impact evaluation, economic evaluation, thinking through what the field of economics can bring to translating evidence-based interventions to highly effective programs, qualitative health systems research, operations research from the industrial and systems engineering perspective, which refers to applied mathematics and modeling as well as ongoing systems analysis and improvement, stakeholder and policy analysis, dissemination research, and a subcomponent of dissemination research, social marketing. So you'll hear and you'll learn about the different methodologies throughout this course, and we'll be demonstrating through case studies how they can be systematically packaged and applied to, again, improve the delivery systems as that link to close the no-do gap. The second component of our definition of implementation science is that we're applying these state-of-the-art methodologies to improve the process as we move from intervention development to implementation and ultimately to scale-up. We see the process of implementation and scale-up as different yet linked. Implementation being the first wave of implementation after an intervention is developed, and scale-up being the process of going to scale after the first wave of implementation. This is a very busy slide, and I won't talk you through it, but it exemplifies why implementation and scale-up are two different sides of the same coin. Here you can see the movement from intervention, design, discovery, efficacy to effectiveness, or the development of the intervention, and ultimately to impact through delivery. And through this animation, you can see when you're talking about implementation, we're focusing on a limited number of individuals, clinicians, local organizations, and health facilities or professional organizations. You can think about a demonstration project for PrEP or a demonstration project for HPV vaccination being carried out in a small number of clinics or districts to get more information for further scale as two examples of implementation efforts. And at that level, the stakeholders you're engaging is pretty small, and it's easier to get your head around how to work with these different organizations. But when we go to scale, we're working with a much broader group of stakeholders that is more complex and more interests. It includes different multinational and national institutions and systems, different ministries, not necessarily just the Ministry of Health, funding organizations, lay press in the media, legislators, and working with these effectively with this diverse group of stakeholders in reaching national scale is a different process than that first wave of implementation. So thinking back to the methodologies that you'll be hearing about in this course, they'll be positioned and used differently depending on if it's the first wave of implementation, post-intervention development, or if you're going to scale at a national level. The REAIM model is an example of an implementation science framework that I like to introduce because it helps to think about the different elements or the active ingredients that come together to have population level impact. And thinking about some of these different components of REAIM, reach, effectiveness, adoption, implementation, and maintenance, helps to understand the different actors that are involved or need to be engaged to have maximal impact on population level health, and whether they're at individual or organizational level. And according to Russ Glasgow, who developed the REAIM model, REACH refers to the target population that is participating in the health intervention as an individual level measure. So you can consider antiretroviral therapy. Target population are those that you are targeting as being stakeholders or eligible for HIV prevention or care and treatment efforts. Effectiveness is also an individual level measure, which refers to how effective is an intervention. Even in the best case scenario, interventions are not generally 100% effective. Adoption is an organizational level measure referring to the proportion of settings or organizations that are planning and adopt the intervention for its implementation. Implementation is again another organizational level measure referring to how an intervention is put into place, and is it put into place as intended in a real-world setting? Are the core components implemented as intended? And maintenance is at both individual and organizational level measure, referring to how a program is sustained over time. And impact is measured as a product of these 5 domains: reach, effectiveness, adoption, implementation, and maintenance. And as we know, when you multiply proportions, you get to smaller proportions, which shows how falling short in any one of these areas can lead to reduction in impact. So I'm going to give you an example beyond the magic pills. So let's use antiretroviral therapy as an example using the REAIM framework. If only half of health systems or delivery systems adopt antiretroviral therapy, and half of those systems choose to train clinicians to deliver it, and half of the clinicians at those systems actually prescribe antiretroviral therapy, half of the patients receive the medicines, and we're going to assume access, adherence, dosage, and maintenance is perfect, then the impact is 0.5 times 0.5 times 0.5 times 0.5, or 6% benefit. So thinking at the population level, public health implications of antiretroviral therapy, we have to be thinking about these different measures beyond just do antiretroviral medicines lead to improved survival amongst those who receive the medicines and are fully adherent, but to think about the systems and organizational level determinants of impact. And getting back to that slide initially about antiretroviral therapy in Mozambique and tuberculosis screening, how can we get those systems that are underperforming to perform better? Because those are going to be key elements to maximizing impact of a highly efficacious intervention, antiretroviral therapy. Implementation science is a new and still being formed field. And there are a lot of different terms that you may have heard or you will hear, like delivery science, scale-up science, operations research, implementation research, diffusion and dissemination research, quality improvement research, health systems research, outcomes research, translational research, knowledge translation, and program science. There's no core definition of implementation science. However, there are attributes across all these definitions that are important to consider. One is implementation science is a multidisciplinary endeavor. We need to be building on the strengths of multiple disciplines to improve delivery systems and ultimately to close that no-do gap and improve population health. In addition, implementation science is a scientific process. We are using the scientific method to ask and answer a question about getting what works to people who need it. In doing so, are trying to provide generalizable information or generalizable results that can improve the implementation and scale up broadly across broad populations. I would not become too concerned about the terminology, however, focus more on the integration of the different research methods into improving delivery systems, because at the heart of closing that no-do gap are those delivery systems. Finally, I would like to end with an introduction to a framework that was proposed in 2010, which helps me think about some of the different terminology and how they're used differently to ask and answer different sorts of questions. So here you can see a framework that is broken down into 3 different areas that define 3 different domains of research. The research domain being operational, implementation, health systems research. The research users being healthcare providers, program managers, health system managers, and policymakers. And then the research utility, or where will the information be used to improve the decision making at a local level or at the broadest level. And according to the authors of this article, which was published before the Montreux Health Systems Global Conference in 2010, operational research or operations research focuses on healthcare providers and to a limited degree program managers as the major utilizers of the research results. And the utility of the research is really to answer questions at the local level with very minimal application to broader areas. So you can think of examples of quality improvement that is carried out at the ward of a hospital or maybe at one clinic or a couple of clinics, where the research design is not designed for generalizability or not necessarily for detecting small differences with a control group. however, is more focused on improving decision-making or targeting efforts iteratively at the local level. Compare operational research to implementation research, which focuses more on the program manager level as well as to a small degree on policymakers and health systems managers, which provides results for broader consumption. And in this case, implementation research is referring to a set of research designs or questions that are trying to compare different strategies for broader consumption. So, for example, different models for implementing antiretroviral therapy, if it should be delivered by nurses or lay workers in the community or physicians. And appropriate implementation research design would be carrying out a prospective trial to try and answer that question across a larger number of clinics in a broader geographic area to provide more generalizable information than operational research. And according to this framework, the health systems research domain is the broadest domain, focusing on the information needs of health systems managers and policymakers to provide the broadest level of information for decision making. According to this article, the authors refer to health systems research as primarily secondary data analysis of large data sets that are longitudinal in nature. So you could think of, as an example, whether the removal of user fees leads to a higher utilization of primary healthcare services and better financial risk protection amongst the poor and marginalized populations. And so it's really the broadest level of evaluating impact using data that tends to be secondary data. Implementation science, in my mind, is really an exciting field. It's a field which is evolving, and because it's evolving, provides an opportunity for students and for practitioners and for researchers to define what this field is going to look like 10 years from now. It has evolved a lot over the past 10 years and needs to evolve more, and that makes it quite exciting. Now, ultimately, at its heart, knowing is not enough. We must apply. Willing is not enough. We must do. Or as Yoda said, do or do not, there is no try. Thank you.